Hello, and thank you for the opportunity to share our clinical experiences in this presentation entitled The Impact of Radiation Treatment on a Mid-Urethral Sling in Women with Gynecologic Malignancies, an experience in a large urology and urogynecology practice. All represented authors have no financial conflicts of interest to disclose during the making of this presentation. Urinary incontinence is a common issue amongst those diagnosed or undergoing treatment for gynecologic cancer. The concurrent finding of incontinence varies in reported literature, however, may be as high as 60% in those with confirmed malignancy. Additionally, those undergoing radiation therapy after formal oncologic diagnosis may in fact develop genitourinary toxicity, which includes voiding dysfunction. These include detrusor overactivity or overactive bladder, stress urinary incontinence, as well as bladder storage disorder. The finding of urinary incontinence amongst gynecologic oncology patients is largely undiagnosed and untreated, as the main focus on patient care is directed at the diagnosis, treatment, and surveillance of malignancy. There is limited investigation into comorbid conditions of the pelvis. Additionally, the medical evidence regarding the efficacy and safety profile of sling placements has been questioned due to the possibility of mesh erosion and sling failure from radiation therapy. Thus, our objective includes a description of clinical outcomes from mid-urethral slings placed either before or after adjuvant radiation therapy for gynecologic malignancies. This is a retrospective, descriptive study that took place between May of 2000 to May of 2019 in a large private office in the Department of Urology and Urogynecology in Buffalo, New York. All patients with a gynecologic malignancy were extracted from the electronic medical records. These patients were then further substratified into those who underwent a mid-urethral sling prior or after radiation therapy. The following are our results. Our study involved a total of 70 women who underwent mid-urethral sling placement. The mean age amongst all patients was 63 years old. It was noted that the preponderance of those mid-urethral slings placed at the time, prior, or after a gynecologic malignancy surgical procedure was of endometrial origin. Of all patients in our study, 13 of those, or 18%, underwent radiation therapy. Those undergoing a sling procedure prior to radiation therapy, all of which were endometrial malignancies, had no mesh complications. Those undergoing a sling procedure after radiation therapy of both endometrial and cervical malignancies observed one complication of mesh extrusion. This was noted in the sole patient who had a concomitant cervical cancer diagnosis. Based on a preliminary analysis, there has been no complications from mid-urethral sling placement before or after vaginal brachytherapy for those with endometrial cancer. There was, however, one incidence of mesh extrusion found in a patient having undergone pelvic radiation for cervical cancer. We attribute this due to the higher dose of radiation specifically for cervical cancer that was administered to the patient. As the sling was placed after radiation therapy, the at-risk and endangered tissue may also have led to the patient being susceptible to mesh complications. To conclude, for those patients with endometrial cancer who are candidates for pelvic radiation therapy, undergoing a mid-urethral sling prior to therapy or thereafter appears to be safe amongst patients. For those patients with cervical cancer who are again candidates for pelvic radiation therapy, there is a potential risk of complications for the placement of mid-urethral sling, including specifically mesh extrusion. Further studies with larger numbers may further shed light on the risks, complications, and safety profile of sling procedures. The following are our references. Thank you for the opportunity to share our findings, experiences, and medical knowledge.